All right, hi everyone. Good afternoon, and welcome to the webinar on behalf of the new practitioner community and the CHP office. This afternoon, we're going to welcome today's webinar entitled "Updates of the 2023 ACR EULAR Antiphospholipid Syndrome Classification Criteria and Review of Management." We are thrilled to have both Doctors Brynna Crovetto as well as Dr. Firas as our guest today. And then Dr. Crovetto is a board-certified pharmacotherapy and critical care pharmacist working at the medical intensive care at New York City Health and Hospitals, Bellevue Hospital Center. Dr. Crovetto received her PharmD from SUNY University of Buffalo, followed by a PGY1 residency at Robert Wood Johnson Hospital, Somerset, and then a PGY2 in critical care at Touro College of Pharmacy with Mount Sinai Hospital. In her current role, she rotates through two MICU services, Precept student pharmacist, and as a member of the ICU Liberation, as well as alcohol withdrawal subcommittees at the health system level. Her current research interest let's see here. So her current research interests include anticoagulation, management of sedation in the ICU, and corticosteroids for septic shock. She currently is elected New York City chapter delegate for the NYSCHP for 2024 and 2025, and is currently serving as their marketing and public relations committee co-chair for the following year. Then we have Dr. Karen as an internal medicine and anticoagulation stewardship clinical pharmacist working at New York City Health and Hospital Bellevue Hospital Center. Dr. Karen received his pharmacy doctorate from Union University College of Pharmacy in Jackson, Tennessee, followed by a PGY1 residency at Baptist Memorial Hospital de Soto, and then a PGY2 in thrombosis and hemostasis at Stanford USD Medical Center. And his current role, he rounds with the internal medicine service teams and serves as the contact for inpatient anticoagulation management. His current interests include calibrated DOAC factor 10A levels, as well as heparin-induced thrombocytopenia and anticoagulation management in patients with antiphospholipid syndrome, which lends itself well to here. And just a couple notes before we get started. For those who have technology issues during the presentation, please use the chat option to communicate with the office, and then we'll make every effort to make sure that we can assist you with resolution of that issue. And then for those that have questions that you would like directed towards the speakers, please make sure to use the question box or the chat option. And then at the conclusion of the program, I'll provide the CE code, and then we'll place that in the chat as well. And with that, I give it over to Dr. Crovetto, and please go ahead and take it away.
Thank you so much for the excellent introduction, and thank you to everyone for joining us here on your lunch hour. I'm happy to present updates to the 2023, ACR EULAR Antiphospholipid Syndrome Classification Criteria and Review of Management. Our objectives for today's presentation are to summarize the pathophysiology and prevalence of antiphospholipid syndrome in the U.S. healthcare system, to compare and contrast previous antiphospholipid syndrome clinical criteria required to make a diagnosis with the 2023 American College of Rheumatology, or ACR, and the European Alliance of Associations for Rheumatology, or EULAR, clinical criteria. Our third objective is to identify the treatment options available for antiphospholipid syndrome and to summarize team strategies for improving outcomes in patients with antiphospholipid syndrome. Antiphospholipid syndrome is an autoimmune disorder. It typically occurs in the presence of antiphospholipid antibodies in the setting of thrombosis or pregnancy loss. The spectrum of APS-related clinical syndromes is broad, and the general definition of APS is a systemic autoimmune disease characterized by arterial, venous, or microvascular thrombosis, pregnancy morbidity in patients with persistent antiphospholipid antibodies. The most common sites are venous and arterial thromboses in the lower limbs and in the cerebral arterial circulation. 40% of patients with antiphospholipid syndrome do have a concomitant diagnosis of systemic lupus erythematosus. APS affects a wide variety of our organ systems, including the nervous system, the kidneys, the heart, the blood, the skin, the blood vessels, lungs, and pregnancy. To highlight some of the effects of APS on different organ systems, in the nervous system, it could present as a stroke, a transient ischemic attack, in the heart as myocardial infarctions, heart valve vegetations, or thickened and leaky valves, in the blood vessels or in the lungs as DVTs and pulmonary embolism, respectively, and in pregnancy, which for us will be explaining in the second half of this presentation. Antiphospholipid syndrome is estimated to have an incidence and prevalence ranging from 1 to 2 cases per 100,000 and 40 to 50 cases per 100,000. Mortality in this patient population is 50 to 80% greater than in the general population. It may be associated with up to 10% of cases of obstetric morbidity and venous thromboembolism. The mean age of diagnosis for antiphospholipid syndrome is reported to be around 50 years of age. Rates are lower in Europe and lower in Asian countries than in the United States, and 50 to 70% of patients with systemic leucemia with positive APLA antibodies progress to APLS. I will explain more about these diagnostic assays in the next slide. There are 3 diagnostic assays that we test for with a concern for antiphospholipid syndrome. The first of which is lupus anticoagulant. This is a functional assay that assesses for the inhibitor effect of antiphospholipid antibodies on a phospholipid-dependent clotting test. A positive lupus anticoagulant is the strongest predictor among patients with pregnancy-related events. It's more specific but less sensitive than anticardiolipin antibodies in predicting thrombosis, but only observed in about 20% of those with ACL antibodies, and ACL is observed in about 80% of those who have a positive lupus anticoagulant. The lupus anticoagulant test involves 4 steps for screening. There's initial screening, which typically involves activated partial thromboplastin time, which shows prolonged phospholipid-dependent clot formation. And then this prolonged screening test persists after mixing the patient's own plasma with normal platelet-poor plasma. The lack of correction suggests that the prolonged clotting time is not due to coagulation factor deficiencies like hemophilia, which is typically corrected with administration of normal plasma. The prolonged screening test is corrected or improved under the addition of excess phospholipid, which does indicate phospholipid deficiency. This is excluding other inhibitors. There's also anticardiolipin antibodies, ACL, IgG, and IgM. This is an ELISA test or an enzyme-linked immunosorbent assay test, which measures for ACL titers for IgG and IgM, and anti-beta-2 glycoprotein 1 antibodies, which also test for IgG and IgM. This is also an ELISA test. IgG does correlate better with clinical manifestations in regards to IgM or IgA. And before we get into the how to test and who to test and when to test, I just want to review positivity. So antiphospholipid syndrome is further broken down into single, double, or triple positive APLS. So going past the previous screen, lupus anticoagulant, your anticardiolipin antibodies, and your anti-beta-2 glycoprotein 1 antibodies. Single positive APLS of these 3 antiphospholipid antibodies, only 1 would be positive. This is generally the lowest risk of thrombotic and obstetric events, and we will review management of single positive and triple positive APLS in the second half of this presentation. Triple positive APLS is exactly what it sounds like. All of the antiphospholipid antibodies are positive, and it's associated with a higher degree risk of thrombotic and obstetric events. Who should we be testing for APLS? Only patients who have a high probability of APS, so patients who have an unprovoked venous or arterial thrombosis, typically in a younger patient population, patients who have thrombosis at unusual sites. This would mean if a patient has a right internal jugular line, develops a thrombosis at that line, that would not be an unusual site for thrombosis. Patient who has an unexplained adverse pregnancy outcome, meeting diagnostic criteria, or patients who have thrombotic events or adverse pregnancy outcomes in patients with other autoimmune disorders. So I did explain a little bit about anticardiolipin and lupus anticoagulant and their prevalence in patients with RA and SLE. So when should we be testing patients for APS? It is not recommended to test during an acute event. So this would refer to patients who are actively pregnant, patients with an acute thrombosis, or patients who are actively critically ill. This can make laboratory assays unreliable. It is also not recommended to test for lupus anticoagulant in a patient receiving anticoagulation. In patients who are receiving active anticoagulation, you can consider testing for anticardiolipin and beta-2 glycoprotein 1, as there's no interference with these assays, and they might meet diagnostic criteria without lupus anticoagulant. When should we be testing for lupus anticoagulant? The timing is consideration refers to the anticoagulant the patient was on, and also in regards to timing of the last time they had received that anticoagulant. So for example, with low molecular weight heparin, you would recommend a lupus anticoagulant test at least 12 hours from the last dose. With vitamin K antagonists, at least 2 weeks after the last dose, or when the INR is less than 1.5. And with direct oral anticoagulants, at least 48 hours from the last dose. And consider longer if the patient does have concomitant renal dysfunction. For diagnostic assays must be persistently positive on at least 2 occasions, at least 12 weeks apart. For ELISA tests, values greater than 40 units are continued positive. So this would be in reference to anticardiolipin antibodies and that glycoprotein B. Antibodies of low positivity are most likely to disappear within 12 weeks. Also to note, there are certain medications that may affect some of these diagnostic assays, such as phenytoin, quinidine, procainamide. A 2-hit thrombosis model is proposed to elucidate thrombus formation in patients with ACS, or APS, excuse me. The first was endothelial injury, and the second amplifies thrombus formation. And beta-2 glycoprotein 1 does not bind that unstimulated endothelia. All of these factors in place with medications to consider, patient being on anticoagulation or not, and also the patient's clinical status, make it markedly important that patients for a positive APS diagnosis to receive diagnostic assays that are persistently positive on those 2 occasions at least 12 weeks apart. I'll now turn it over to Firas to explain the differences with the 2023 ACR EULAR antiphospholipid syndrome classification to the 2006 Sapporo criteria.
Awesome. Thank you, Brynna. So like Brynna mentioned, we're going to discuss the differences between the previous recommendations and the new recent 2023 ACR EULAR antiphospholipid syndrome classification. Before I do want to mention a little bit about the new set of recommendations. So this new criteria is based on a weighted point system of symptoms, physical examination findings, and lab results. It's 8 domains divided into 2 types, so a clinical domain and a lab domain. And then it's further broken down into 6 clinical domains and 2 lab categories. The new classification include an entry criteria followed by the additive weighted criteria, which I mentioned just above. So the new APS criteria versus the 2006 revised Sapporo classification criteria, which we have been using and utilizing, has a specificity of 99% versus 86%, and a sensitivity of 84% versus 99%. So our new set of recommendations are going to be a little bit more specific than the revised Sapporo set of recommendations. Perfect. I wanted to include this snippet of the 2023 ACR EULAR antiphospholipid syndrome classification. So as you can see, there's that entry criteria, and basically it's at least 1 documented clinical criteria listed below and throughout the 6 domains, plus a positive antiphospholipid antibody test, which Brynna reviewed previously, and then if absent, you would not attempt to classify as APS. And if present, you would apply the additive criteria below. You would calculate the score, and at the bottom of the slide, you'll see, once you get the total score, you'll classify as antiphospholipid syndrome for research purposes if there are at least 3 points from the clinical domain and at least 3 points from the lab domain. So let's dig a little further in it. It can seem cumbersome. So breaking it down, the entry criteria is at least 1 clinical criteria plus 1 positive antiphospholipid antibody test. And that could be a lupus anticoagulant test or a moderate to high titers of the anticardiolipin or anti-beta-2 glycoprotein antibodies, IgG or IgM, within at least 3 years of the clinical criteria. I thought it would be simple to show the old, or revised Sapero 2006 categories and our recommendations on how we get to diagnosing APLS versus the new ACR, EULAR categories. So to begin with, the old revised Sapero guidelines, if we want to go to the next slide for just a minute. Perfect, thank you. You'll see that the old revised Sapero 2006 guidelines, you would need at least one or more clinical and lab criteria to diagnose APLS to diagnose APLS. When compared to the new guidelines set of recommendations, you would need three or more clinical points of each, 3 or more clinical and 3 or more lab points to confirm APLS. Next slide, please. So honing in your attention on the clinical side of things, in terms of thrombosis, you'll notice in the old revised Sapero guidelines, it just basically demonstrated a thrombosis is a venous, arterial, or a small vessel. And that was basically, an possible reasoning for APLS. However, when compared to the new set of recommendations, it breaks it down between venous and arterial. And in the venous side of things, we break it down further into a high VTE risk profile versus a low VTE risk profile. With arterial, it's further broken down into a high CVD risk profile versus a low CVD risk profile. I will go over the what makes a patient high or low, but then you would correspond the risk to the points that you will then collect and add towards the end. One thing you'll notice as well in the new ACR EULAR set of recommendations, it also factors in microvascular involvement, whether it's suspected or confirmed, cardiac valve, whether we have thickening or vegetation, and then thrombocytopenia. These categories were absent from the revised Sapero 2006 set of recommendations. Jumping into the lab aspect, you'll notice that in the revised Sapero set of recommendations, it says you need one or more of the following on 2 or more occasions greater than or equal to 12 weeks apart. So either a lupus anticoagulant, a positive lupus anticoagulant result, or a positive anticardiolipin antibody. And I want you to notice how it doesn't decipher between IgG and IgM. It just says IgG and IgM or IgM in medium or high titers. And then it also has the same anti-beta 2 glycoprotein antibody. And again, it does not decipher between IgG or IgM. If you notice on the ACR EULAR new set of recommendations, it goes on to break the anticardiolipin or anti-beta 2 glycoprotein by IgM and IgG. As Brynna mentioned earlier in this presentation, IgG is generally associated with more complications than IgM. And I'd like you to take into effect, earlier when I presented, I mentioned how the new set of recommendations aim to more of a specific, trying to be more specific in diagnosing. So because IgG is generally more associated with more complications than IgM, hence why IgG, if you encounter high titers, you are generally awarded more points. And it's also broken down by the antibody titers. So moderate is going to be greater than or equal to 40 all the way to 79 units. And then a high titer is going to be greater than or equal to 80 units. So there's that big difference right there in terms of the previous revised Sapero versus the new EULAR set of recommendations. The next thing is, and my circle kind of went haywire here, but lupus anticoagulant, whether it's one time or persistently positive, by persistent, that still takes the same definition from the previous revised Sapero, where it's greater than or equal to 12 weeks apart. So if they're persistently positive, they will be awarded more points when compared to just a one-time positive lupus anticoagulant results. Like I mentioned earlier, I'm going to describe to you guys what makes a patient high risk for VTE. So based on the previous slide when I mentioned if they had a venous thrombosis, we then would further classify patients on high or low VTE risk profiles. So high-risk VTE is defined based on one or more major or two or more minor VTE risk factors. So a major risk factor would be active malignancy, hospital admission, major trauma, and or surgery. Minor would classify a patient as active systemic autoimmune disease or active inflammatory bowel disease, acute active severe infection, central venous catheter, hormone replacement, so estrogen-containing contraceptives, in vitro fertilization treatment, long-distance travel or prolonged immobilization, obesity or postpartum period, and surgery. Now, jumping in, if the patient did present with a thrombosis that was arterial, then we would further classify high risk versus low risk CVD. So a high risk CVD is defined based on one or more high CVD risk factors or three or more moderate CVD risk factors. So that a high risk is considered arterial hypertension, chronic kidney disease, diabetes with organ damage, hyperlipidemia. A moderate risk is going to consist of arterial hypertension, current tobacco smoking, diabetes without organ damage, hyperlipidemia, obesity. Now, I mentioned previously the kind of categories that weren't involved, the categories that weren't in the revised SAPERO, which involved microvascular involvement. So if patients were suspected versus confirmed or established, if they were confirmed, they would get 5 points. If they were suspected, they would get 2 points. So what does suspected mean? So that's going to be livedo racemosa by physical exam, livedoid vasculopathy lesions, and that's also by physical exam. Antiphospholipid antibody nephropathy by physical exam or lab test, and pulmonary hemorrhage by clinical symptoms and imaging. Now, established or confirmed, which will warrant you 5 points, will be livedoid vasculopathy, and that's by pathology. APL nephropathy by pathology, pulmonary hemorrhage by broncholavage or ball or pathology, myocardial disease, and that's by imaging or pathology, and then lastly, adrenal hemorrhage or microthrombosis by imaging or by pathology. I know that was a little bit, but I wanted to just bring your attention to the real big key changes from the 2006 SAPERO criteria. So like I mentioned earlier, we isolated IgM positivity. It's less likely to represent true APS than IgG positivity. For venous and arterial thrombotic events with other risk factors are less likely to represent true APS, IgG versus IgM. So consideration of thrombosis risk profile is important for a clinical diagnosis. And non-thrombotic manifestations are included in the clinical diagnostic criteria. So like those subsets that were added that were not in the 2006 SAPERO criteria, and that's the cardiac valve pathology, thrombocytopenia, and microvascular disease. And with that being said, I will turn it back to Brynna in regards to the treatment and management of APLS.
Thanks, Firas, for giving us an overview of the revised 2006 criteria and how they compare to our new 2023 ACR and EULAR criteria. Next, I'll be discussing treatment and management of patients with APS. Let's talk about primary prevention first. So these are patients who typically do not have active thrombosis. These are high-risk patients who have a positive lupus anticoagulant, 2 or 3 positive antiphospholipid antibodies, or a persistently high antiphospholipid antibody. Patients who are high risk but have no history of thrombotic events are recommended per the guidelines to receive low-dose aspirin. So this would be your baby aspirin, 81 milligrams for most patients. And patients who have systemic lupus erythematosus but no history of thrombosis or pregnancy complications with a high-risk APL profile are recommended to also receive prophylactic low-dose aspirin. For those who have a low-risk APL profile, they are considered to be recommended prophylactic low-dose aspirin. And in non-pregnant patients with a history of obstetric APS, with or without systemic lupus, are recommended to receive prophylactic low-dose aspirin after an adequate risk and benefit is evaluated. Patients with systemic lupus erythematosus who do test positive for APLA are potentially recommended to receive hydroxychloroquine, as it also does have thromboprotective properties. In patients who have a venous thrombosis, so secondary prevention, they already have a clot, where they have definite antiphospholipid syndrome and a first venous thrombosis. So to pawn back, when we're talking about definite antiphospholipid syndrome, that's persistent positivity greater than 12 weeks apart, following the criteria that Firas had demonstrated in the 2023 ACR and EULAR criteria. It is recommended for patients with a first venous thrombosis and definite APS to receive warfarin with an INR goal of 2 to 3. This is typically initiated with a heparin bridge, as we're aware. Factor inhibition does take time, and we'll see full effect of this agent with around 5 days of utilization. For patients with an unprovoked first venous thrombosis, anticoagulation should be continued long-term or indefinitely. Patients with an unprovoked DVT and are found to be lupus anticoagulant positive are found to have a 40% increased risk of recurrent thrombosis if anticoagulation is discontinued. And if anticoagulation is continued, this patient population, even still, has a 22% risk of recurrent thrombosis. The question always comes up, so what about direct oral anticoagulants? It may be used in patients with venous thrombosis and single or double antibody positivity, but I'll explain a little bit more regarding patients who are triple positive and why warfarin is preferred for those patients. In patients with an arterial thrombosis, warfarin is preferred over DOACs. The INR goal is debatable. 2 to 3 is primarily used, while some use a higher goal of greater than 3. In patients who are unable to tolerate warfarin, you may recommend low molecular weight heparin if patients cannot tolerate or show no response to warfarin. If patients have a recurrent thrombosis despite adequate warfarin, the recommendations per the 2023 guidelines are to add aspirin to warfarin, changing to low molecular weight heparin, or considering an INR goal increase, which is referred to as high intensity anticoagulation. This is a consideration. However, the risks and benefits of increased bleeding with an increase in warfarin INR goal, or in addition of an antiplatelet agent such as aspirin to warfarin, must be considered in preferring these regimens for patients. Frequent INR checks are important for these patients who are receiving warfarin, as well as counseling patients regarding dietary restrictions and new medications. An important consideration is that lupus anticoagulant positivity can also cause falsely prolonged activated partial prothrombin time, which is APTT, prothrombin, which is PT, and INR. Proposed methods to avoid this include measuring prothrombin levels or factor 10 activity, which is unavailable in all laboratories, but may be a consideration for these patients. If patients are unable to achieve target INR despite good adherence, a consideration for DOACs can be made. However, there might be some consideration for utilization of dabigatran or brand name Pradaxa to be more effective than other direct oral anticoagulants. Potentially, this might be related to its anti-factor 2A mechanism, And elderly patients with stroke who have low titer anticardiolipin antibodies, or ACL, are recommended to receive low-dose aspirin, and low titer anticardiolipin antibodies may be incidental and might not be the cause of the stroke. So just some considerations for arterial thrombosis with secondary prevention. So what about triple positivity? So this refers to patients who are lupus anticoagulant positive, they're anticardiolipin positive, they're anti-beta 2 glycoprotein 1 positive. What do you do? Several trials have found that direct oral anticoagulants were inferior to warfarin. In these trials, they were typically terminated early due to excess of thrombotic events in patients treated with direct oral anticoagulants over those treated with warfarin. These trials have compared the efficacy of rivaroxaban and apixaban to warfarin, finding them to be inferior. Because of this, several societies recommend against the use of DOACs for patients diagnosed with APS and triple positivity. And some of these even go further and recommend that any patients diagnosed with APS and a thrombotic event, either venous or arterial, should be treated with warfarin over a DOAC. I'll hand it back over to Firas to explain treatment and management in our obstetric population.
Thank you, Brynna. So pregnancy is a really major component of APLS. All pregnant patients should be under surveillance during their pregnancy. And typically the goal of treatment is to reduce risk of adverse fetal outcomes, and that is dictated by the patient's clinical scenario. So we know that warfarin is teratogenic and it should be largely avoided in pregnancy. And we do know that DOACs do lack safety data. With pregnancy management, typically our go-to is going to be low molecular weight heparin or unfractionated heparin. Typically, we're going to prefer low molecular weight heparin over unfractionated heparin because of the better bioavailability, the longer half-life, which is convenient for once-a-day dosing, and lastly, the lower risk of thrombocytopenia and osteoporosis associated with low molecular weight heparin as opposed to unfractionated heparin. In terms of management, if a patient were to have a positive APLA, but they have no history of arterial or venous thrombosis, if this is their first pregnancy, no treatment is indicated. However, if we're accounting a signal pregnancy loss at gestation less than 10 weeks, that is still no treatment indicated. A high-risk APLA without history of thrombosis or pregnancy complication is when you would consider the baby aspirin or low-dose aspirin daily. Now, if a patient has had a history of 3 or more pregnancy losses at gestation less than 10 weeks, or a pregnancy loss at greater than 10 weeks, low-dose aspirin in combination with prophylactic dosing of unfractionated heparin or low molecular weight heparin throughout the pregnancy could be considered. Aspirin should be started before conception, and aspirin and heparin, low molecular weight heparin, can be discontinued 6 to 12 weeks postpartum. So the reason why is because postpartum anticoagulation is generally continued for at least 6 weeks post-delivery due to that increased thrombotic risk during that time frame. Anticoagulation can be resumed 6 to 12 hours after a cesarean delivery or 4 to 6 hours after a vaginal birth, unless there is a significant risk of bleeding or a post-delivery complication. Warfarin and heparin are not contraindicated during breastfeeding, as there is a low risk of hemorrhage. So in terms of a history of delivery prior to the 34th gestational week due to eclampsia, preeclampsia, or other recognized features of placental insufficiency, typically the go-to would be low-dose aspirin or low-dose aspirin plus prophylactic heparin based on the patient's risk profile. If there is a history of a less well-defined criteria, so if the 2 spontaneous miscarriages prior to the 10th gestational week, or a delivery after the 34th gestational week due to eclampsia or preeclampsia, low-dose aspirin or prophylactic heparin, depending on the patient's risk profile. In women with definitive obstetric APS with recurrent pregnancy complications, despite combination treatment with low-dose aspirin and prophylactic heparin, low molecular weight heparin. So this is in our patients that have basically failed baby aspirin and prophylactic doses of our heparins. You could consider increasing the heparin dose to a therapeutic dose, or adding hydroxychloroquine or a low-dose prednisolone in the first trimester could be considered. With hydroxychloroquine, there has been some data that it does lower thrombosis risk. So that is why it is sometimes considered in this patient population. However, if all else fails and your last line treatment would be intravenous immunoglobulin or IVIG in select cases. So that is going to be your last resort. In women with a history of thrombotic APS, a combination treatment of low-dose aspirin and heparin at therapeutic dosage during the pregnancy is recommended. So there were observational studies that treatment with low-dose aspirin and therapeutic dose heparin were associated with an average of 79% live births. So switching treatment from warfarin to therapeutic dose low molecular weight heparin would be recommended as soon as pregnancy is confirmed, and ideally before the 6th gestational week due to the teratogenic effects of warfarin. I will go ahead and hand it over to Brynna, who's going to discuss how we can improve team outcomes and the bottom line.
Thanks, Firas. I'll be reviewing improving team outcomes and the bottom line. In patients with antiphospholipid syndrome, management typically involves an interprofessional team approach involving multiple specialties. This can involve primary care to identify patients with risk factors for antiphospholipid syndrome, with hematologists and rheumatologists who are responsible for diagnosing, managing, and follow-up. This also involves anticoagulation clinics, and if any other specific organ system is involved, other specialties should be consulted. I really wanted to take a moment here to review a lot of what we've discussed today. This is a very complicated disease process that involves proper timing of diagnostic assays, as well as identifying risk factors for positivity of those assays. So coordination with pharmacists, if able, is key, and coordination with pharmacists for consideration of INR monitoring, INR dose adjustment for warfarin and anticoagulation clinics can be very beneficial for this patient population. In cases involving pregnancy, obstetrics and maternal fetal medicine specialists should be consulted. So Firas did review in what patient population should be considered for anticoagulation, what anticoagulant agents are appropriate for patients who are currently pregnant, and also when these anticoagulant agents should be continued or discontinued. This should also be done in coordination with the patient's obstetrics and maternal fetal medicine specialists. And also, just to review, enoxaparin dosing can vary depending on the patient's weight during pregnancy. So proper anti-10A monitoring to ensure we're hitting effective anti-10A peaks is important for these patients who are pregnant on low molecular weight heparin. And again, what can we do? We can identify drug interactions that can impair the effects of our anticoagulation to work properly. We could appropriately dose and ensure the patient has an appropriate INR response. I think also important here is to recognize appropriateness of agents utilized. So for example, enoxaparin, we obviously have to consider renal dysfunction. If a patient needs to be on enoxaparin or does not qualify for alternative anticoagulants, How are we dose adjusting? How are we monitoring the efficacy and safety of those agents? And really, it plunges down to it completely to communication, communication, communication. Communication among the interprofessional team members managing these patients with antiphospholipid syndrome is vital. And I cannot stress enough that a key team member in this is the patient. So we went through some of the treatment management strategies, and the patient should have input on what they are able to utilize. Of course, keeping to evidence-based medicine, but having them involved to improve healthcare team outcomes. So what's the bottom line? Select vitamin K antagonists or warfarin as first-line therapy among patients with thrombotic antiphospholipid syndrome. Patients with triple positive, so that lupus anticoagulant positive, anticarbolipin positive, and that anti-beta-2 glycoprotein 1 positivity should also be receiving warfarin. Of course, something to highlight is patients who are pregnant should not be receiving warfarin, which is why low molecular weight heparins are a preferred anticoagulant, as warfarin can be teratogenic. We want to select a usual target INR goal for most of our antiphospholipid patients. This is an INR goal of range 2 to 3. If the patient is unable to achieve our target INR goals, we could consider those alternative anticoagulation agents as discussed. We want to individualize our peri-procedural or bridging anticoagulation management to the patient, being mindful that an increasing uncertainty exists for thrombosis risk reduction, except with bridging, bleeding risk is thought to remain. So in consideration of patients who might present on warfarin, who is appropriate for bridging with a parenteral anticoagulant, and who might be at an increased risk of bleeding is something that pharmacists can also help dictate in an inpatient setting. We also want to pursue cardiovascular risk reduction. So Firas gave a great overview of all of the different microvascular changes, as well as patients who are high risk for cardiovascular disease and their new implications to our ACR and EULAR criteria from 2023. You could consider that high target INR, which is a range of 3 to 4 among select APS patients, and patients with recurrent thrombosis may also be considered for aspirin in patients with a history of arterial thrombosis. In a patient with recurrent arterial or venous thrombosis, despite adequate treatment, you can consider changing antithrombotic therapy. So that's adding aspirin, increasing your INR target, or switching to your low molecular weight heparin. Also, addition of adjunctive therapy, such as hydroxychloroquine, which might have thromboprotective effects. In patients who have cardiac valve lesions or vasculopathy, you could consider aspirin alone. And patient values and preferences should be considered when selecting extended phase antithrombotic therapy. So how long do these patients require therapy? Is this lifelong? Majority of our patients with antiphospholipid syndrome, as demonstrated in our treatment and management slide, might be on lifelong or indefinite anticoagulation therapy. And these are considerations that need to be reviewed on any annual visit that the patient presents. So what's the bottom line as well for caution? So caution selecting direct oral anticoagulants in patients with antiphospholipid syndrome. There is some suggestion that dabigatran might be more effective as a DOAC than our other direct oral anticoagulants, but in patients who have triple positivity, direct oral anticoagulants were found to be inferior with an increased risk of thrombotic events in comparison to vitamin K antagonists or warfarin. You also want to caution with bleeding risk when you're adding antiplatelet therapy, such as low-dose prophylactic aspirin to anticoagulation. Also want to caution with bleeding risk if you're electing a higher target INR goal over a usual target INR. And combining a higher INR with antiplatelet therapy, so adding those two together, is going to have a higher increased bleeding risk than either one alone. There are many uncertainties, though, to antiphospholipid syndrome management. Warfarin is preferred. However, direct oral anticoagulant inhibitors may be selected upon shared decision-making with the patient. So back to improving healthcare team outcomes, we want to ensure that our patients are involved in shared decision-making. We also, though, want to explain to them some of the literature that exists, especially if they are triple positive, that warfarin is preferred due to an increased risk of thrombotic events with DOACs. If point-of-care INR is elected, you also want to consider concordance with plasma-based INR, since the point-of-care INR testing for these guidelines may not be recommended. There are no randomized comparisons of anticoagulation with or without aspirin for secondary prevention of arterial thrombosis. Some providers use aspirin with anticoagulation for a first arterial event, while others reserve it specifically for refractory patients. The preferred antithrombotic strategy is unknown, though. In patients with recurrent thrombosis on warfarin, your options include increasing that INR target range and or adding antiplatelet therapy, multidisciplinary collaboration, and consideration of adjuvant treatments, including statins, anticomplement therapy, and hydroxychloroquine. I think really to reiterate here, there are many uncertainties with antiphospholipid treatment criteria. There are studies that still need to be done in consideration of what agents could be preferred, especially as adjuvant treatment duration, and then also in consideration of anticoagulation with or without aspirin for secondary prevention in patients who present with arterial thrombosis. Thanks for tuning in to our updates to the 2023 ACR and EULAR antiphospholipid syndrome classification criteria and review of management. I'll now turn it back over to Firas if he has any additional comments before opening it up to the group for questions. Thank you.
Thank you, Brynna. So yes, just generally APLS, like Brynna mentioned, there's more uncertainties I think there are with certainties here, unfortunately, and it is a disease state that is that has like a clinical conundrum, if you will. Typically in the inpatient setting, I would not recommend, typically what I do see happening for the most part, if we were suspecting APLS in a patient that is in an acute event, I would not consider testing in the inpatient setting. And I think that is something that's done quite frequently, unfortunately, that we do test and we get these labs because when patients are admitted, we have them on several different anticoagulants, obviously due to the acute event. In addition to the acute event on itself can cause some false positives with the lab. So typically, I feel like it's a stepwise approach in terms of inpatient. Our goal is to stabilize the patient, consult team and kind of manage them in a way where we can get testing done outpatient. And then in the outpatient setting is when in like anticoagulation clinics or, your hematology appointments, that's where they would want to manage and ensure that anticoagulation is stopped appropriately prior to testing and getting a confirmation. That is kind of the biggest thing that I see. And there's a couple of minute details as well, but I will leave it open. I think we do have a question. Let me take a look and I can try to see. So we got a question about patients with triple positive, but they're non-adherent to warfarin testing follow-up. What would you do? Is there still some benefit of using a DOAC if they only want to use an oral agent? So like Brynna mentioned in her part of the slides, there were trials that showed that DOACs were inferior to warfarin due to the increased thrombosis risk with triple positive APLS. My recommendation is typically what I've seen in practice, in anticoagulation clinics, et cetera. If patients are not going to be compliant to one agent, switching the agent necessarily won't change compliance. Now, the question was in regards to testing and follow-up. This is where we can maybe try to use our social work powers or our mindset where we could try to make it easier for the patient and maybe figure out what obstacles are in our way. For example, some anticoagulation clinics are able to supplement patients with point of care testing, so similar to a glucose meter. And I've seen patients improve in terms of following up. That way they don't have to go, if weather is a burden, or going and transport to the clinic to get their INR tested. So that's what I would do. I would maybe try to see if we can try to get the patient on a point of care testing. Education, I think, is the biggest thing. Contacting the patient and letting them know this is, this is a pretty serious thrombosis risk, and it's vital that we get your INRs and make sure you're therapeutic. But I hope that answered your question.
And I'll also add that it is a shared decision process with the patient themselves, and making sure, like Firas was saying, to educate the patient on the literature that does exist, that these agents could be inferior to warfarin, but consideration of anticoagulant use in these patients can be quite difficult. Some of these patients require lifelong anticoagulation. They might not be compliant with, INR checks, like Firas was saying, maybe point of care testing, if it's available, could be an option for these patients who might not be able to get into anticoagulation clinics as readily. But it is a conversation that we anecdotally have had with hematology. And that also begs the question of some of these agents that might have more data, such as dabigatran, which is still, a smaller subset of data than with vitamin K antagonists, but would that be an option for these patients? I think it's a difficult question, but it's something that we need to discuss with our interdisciplinary team.
Sounds good. One additional question I have here is that there was mention of using, INR goals that were 2 to 3, then potentially greater than 3. There's a comment about patients that had recurrent secondary prevention and then are having multiple events using greater than 3. Are there any criteria that you would use for an INR goal greater than 3 in patients that have their first clotting event for secondary prevention?
I can take this one. And Brynna, if you have something to add after, I'd love that. So if patients, like increasing the INR goal, definitely. There is, if the lab is capable of doing this, I have had patients in that same predicament where sometimes INR doesn't necessarily tell us doesn't necessarily tell us the state of how anticoagulated the patient is. And I've reverted to using chromogenic factor 10 levels. And with these levels, they're not widely available, but if they are available, try to see if you can consider that. Usually it's going to be like an outpatient lab thing that the anticoagulation clinic might be able to do. But typically how that's done is in patients that are anticoagulated, we typically want chromogenic factor 10 levels between 20 to 40%. Sometimes we aim 20 to 30%. And we collect that level as well as an INR. And I have seen it where a patient's, let's just say their chromogenic factor 10 level is 20% or 25 to make it easier, 25%. However, their INR is 3.1. And then we'll do it again a couple weeks later, and their chromogenic factor level is 30%, and then their INR is 2.9. We want to try to get a connection between INR and the chromogenic factor 10. And by just telling us that, we could just kind of coincide, because the chromogenic factor 10 is going to be a little bit more accurate in telling us how anticoagulated they are. And that could be a means of increasing the INR goal. And in that sense, if that is something that we were going to do, that is an option, is to check for chromogenic factor 10 levels if available. But again, it is a whole clinical conundrum, and it's sometimes difficult to obtain these labs. I don't know if Brynna has anything to add to that.
Yeah, thanks for us. I think the only thing that I'll add is when you look at those 2023 ACR and EULAR criteria, they demonstrate that there's limited evidence for increasing the INR goal or what to do in the scenario of recurrent thrombosis when a patient has achieved a target INR goal of 2 to 3. And I think that's the main word here, achieved. So we want to ensure that our patients are adherent to treatment, they're getting frequent INR monitoring or in a self-monitoring program to make sure that their anticoagulation management is optimized before we add on an additional agent like aspirin, or increasing that INR goal, or changing an agents to low molecular weight heparin. Since it's mostly from case series that they've taken this evidence, just to ensure that we're not increasing bleeding risk unnecessarily, just going back to those basics. So is the patient adherent to treatment? Is the patient appropriately counseled on drug-drug interactions or drug-food interactions? Are they frequently being monitored in terms of their INR? And is it appropriate to make those changes?
Thank you. Last question. When patients are diagnosed with suspected antiphospholipid syndrome, initially they inpatient, and we're going to wait on testing until 12 weeks. Do either of you have a consensus on sending those patients home on a DOAC or warfarin? One of our audience members says they worked at two different institutions, that it was kind of hematologist specific on which they were choosing, which approach.
I can take this one. I would agree as well. I think it's a conversation that's usually had with our hematology team in consideration for risk. Generally, our hematology here, and for us, you can correct me if you've had an alternative experience, will place patients on a direct oral anticoagulant to ensure that the patient has persistently positive diagnostic assays, since this is a criteria for diagnosis. However, I have seen anecdotally hematologists who feel like the risk of that patient themselves was quite high and put them on warfarin in the interim. I don't know if for us you've had an alternative experience to me that maybe you can speak to as well.
Thank you, Brynna. No, I've actually had similar experience to you. Typically, us as the pharmacist, I would help maybe in deciphering a DOAC versus warfarin. So, again, going back to Brynna's slides on who to test, when to test, typically APLS, when we're thinking of your typical APLS patient, we're thinking of somebody who's going to be younger, possibly has, the screaming criteria of APLS, pregnancy loss, et cetera. Typically, let's assume this patient, and again, this is why I think it's all per patient specific factors. Let's assume this patient is like highly suspective of APLS. A lot of providers, like Brynna mentioned, would not, I feel like, take the chance and maybe would do warfarin in that sense. And I've seen providers go the other way, where we suspect APLS, and we are, waiting in that 12 weeks, but, the suspicion is not that high, if that makes sense. And they might send patients on DOAC. And granted, the other thing that takes into consideration that Brynna mentioned earlier in this presentation, with DOACs, we're concerned with like renal function, with Xarelto. There's other factors that could impact, which agent we use outside of APLS. So obesity is kind of controversial. Bleeding risk. Are the patients, is this 80-year-old patient who we're going to start on warfarin? And, do we feel like they're really going to understand how warfarin works and the follow-up and the INRs? So there's a lot that goes into it. And I've seen it done. It's pretty normal to see that different, academic centers have done it differently. I feel like it's just patient specific, practice specific, and, the options that we have available. I hope that made sense.
Yeah, it does. Thank you both. Excuse me. So that puts us at time. So I want to thank both Brynna and then Firas for their presentation, and then for the Q&A session that we have here. So now we'll go ahead and give you the CE codes for today. And